Thanks for joining. First, just want to say, please join us for next week's Grand Rounds, given by Dr. Al Saban on endoluminal therapies for obesity, current practice, and emerging technologies. And now I'll be introducing Dr. Shaya, and then she'll be introducing her co-presenters. Dr. Shaya is a distinguished professor in the Department of Practice Sciences and Health Outcomes Research at the University of Maryland School of Pharmacy, an affiliate professor in the Department of Epidemiology and Preventive Medicine at the School of Medicine. She received her Doctor of Philosophy in Health Policy and Management from the Johns Hopkins Bloomberg School of Public Health, completed an academic research fellowship at the Academy of American Colleges of Pharmacy, and completed a postdoctoral fellowship in pharmacoeconomics and outcomes research at the University of Maryland School of Pharmacy. She currently directs the informatics core in the UMB Institute for Clinical and Translational Research and is executive director of the School of Pharmacy's Behavioral Health Research and Resource Team. Today, she and her co-presenters will be speaking on Maryland's opioid academic detailing program. Please give a warm welcome to Dr. Shaya and her co-presenters.
Okay, thank you very much. We are delighted to be presenting at Grand Rounds today. And how I like to say it is we are the last mile, which means that we are what translates data into action. And today what we are presenting is really an example of a program of academic detailing where we take everything we learn from research and actually apply it into practice. And in that vein, this is part of our core under the ICTR, which is dissemination and implementation. And today I will be presenting my three co-presenters, as well as some of our sponsors at the Maryland Department of Health. So let me start with our sponsors, Adrienne Catwell and Susan Deng. Adrienne is in charge of provider outreach, and Susan, provider engagement. And all of you at some point will be in touch with them, I'm sure, one way or the other. Their program is the Prescription Drug Monitoring Program, PDMP. We also have Brian from the PDMP. Brian will be speaking, and Brian is a health policy and analysis program coordinator. We also have the two other presenters, Nicole Silfon and Kyle Whitby. And Kyle is health program specialist in our team, Behavioral Health Technical Assistance Program, and Nicole is associate director of that program. With this, I'm going to open it up so that we don't take up more time, and we are going to be showing you research in action. So these are people in the field who are actually practicing public health and practicing engaging providers with what we have learned about opioid prescribing from the perspective of communities and patients. So here we go. Hi, Brian.
Sorry about that. Hello, everyone. Thank you for having us. So my name is Brian. I'm from the Maryland Prescription Drug Monitoring Program. Many of you do already know about the PDMP. Some of you may associate us with CRISP. I mean, we do work hand in hand with CRISP, but so pharmacies and dispensing practitioners who dispense controlled medications, that data is reported to us. And so we are contracted with CRISP, which is the state's designated health information exchange. The data is shared with them so that they can create a portal for you all to access and view your patient's data. There is currently a use mandate in place. So every time an opioid or benzo is prescribed and initiated, it is required for the prescriber to access 4 months worth of the PDMP data and every 90 days until the treatment has ended. I do suggest doing an interstate query on the CRISP portal. We do have the ability to search other states. It is an added search. So when you review a patient, immediately it shows you what the Maryland dispenses are, but you can do an interstate query to show you if the patient has gone to other states. So anyway, all of this, it allows us to do what it shows on the slide here. It allows us to support prescribers and dispensers by promoting the professional education, informed clinical decision-making, best practices, and innovations to ensure Maryland patients experience optimal access, efficacy, and safety in connection with controlled substance pharmaceuticals. Now, within the PDMP, we have the provider engagement unit, and that's primarily run by Adrian and Susan that Dr. Shaya had introduced you to. They manage what's called Detail MD, and that's the Maryland Opioid Academic Detailing Project. Next, I'd like to give you an overview of the BERT program. They are the Behavioral Health Resources and Technical Assistance Program at the University of Maryland School of Pharmacy. They provide technical assistance to guide communities across Maryland in addressing substance use prevention. So we partner, I should say, the provider engagement unit of the PDMP partners with the BERT program in order to create educational material that is then disseminated by the Detail MD program throughout Maryland. And so all of this goes into helping the BERT program accomplish their mission to improve public health by bridging the gap between research and practice through technical assistance and evaluation. Some of the objectives that we'll be talking about today, we're going to summarize key background information about the opioid epidemic, explain the role of prescribers in addressing the opioid epidemic, identify indicators of diversion or misuse of controlled substances, describe the purpose and principles of academic detailing, outline key components of the Maryland Academic Detailing Project, also known as Detail MD, and apply strategies to build and strengthen provider relationships. First, before we go into what Detail MD is, I'm going to provide you with some data around what the opioid epidemic looks like in Maryland right now. First, I'll provide some disclaimers. This data comes from two main sources. It's the Vital Statistics Administration and the Office of the Chief Medical Examiner. The VSA has, every time there is a patient death, the data is recorded with the VSA. If the patient experienced an overdose, the OCME provides the data on what substances were in the patient at the time of the overdose. They do the autopsy reports and they conduct the post-mortem toxicology screenings. I will have some data from the Maryland Overdose Dashboard, but the underlying data does also come from the VSA. So really, it's mainly the VSA information. I will note that counts from 2022 to 2025 are considered preliminary. They are subject to change if OCME death investigations, when they're finalized, the numbers can tend to change. This is a screenshot of the overdose dashboard. Right now, I'm showing the total overdose deaths over time. You can see from 2014 until 2021, overdose deaths per year have been increasing. They did start to decline after 2021 when it peaked with 2,800 patients that had passed away that year. Last year, it is now down to 1,405. So that is, we do see that as a very big improvement. Now, people can debate on what is causing this. Maryland does want to acknowledge the efforts that we are promoting, such as naloxone administration, access to recovery services. I mean, we do promote that very heavily, and we do want to acknowledge that. But at the same time, I do also want to acknowledge that in 2023, there was a crackdown on precursor material where the Chinese government had actually cracked down on some of the precursor material that was coming here to the United States. So that can't be ignored. That should also be acknowledged as well. So the next three slides are going to come from it's a SUDORS report. SUDORS stands for the State Unintentional Drug Overdose Reporting System. Almost every state has a project like that. It's funded by the CDC. And so SUDORS helps states analyze the data that they collect. And so they provide reports for physicians and providers. I do have some copies of the report, the recent report, in case any of you would like to take a look at it. But so basically, if you're looking at this chart, you can see that 91.5% of cases had some sort of an opioid in them, in the patient's or in the decedent's system. It is also important to note that 51.4% of cases had some form of a stimulant in them as well. And when looking at the underlying data year after year, the stimulant concentration does seem to be increasing. So that is something to be to take into consideration. So this chart shows the most common locations that decedents have been found when they experienced an overdose. 49.1% happens to be at the person's home. All the other locations, it really doesn't seem to come close. The number one location does happen to be at the decedent's home. This chart shows the frequency of naloxone administration over time. I will point out that 2018 data, the reason that that is separated from the other years is because 2018, the numbers were only factoring opioid overdoses, whereas from 2019 onward, it's opioid and other substances included. But what I would like to point out is that the first responders primarily used to be the number one reason naloxone was first administered. But as you can see, the number of lay persons administering naloxone is becoming more and more of an occurrence. I would also like to point out, for those of you who would like to come up and look at the SUDORS report that I have here, there's another chart that shows the types of bystanders that were present at the time that either the decedent was experiencing the overdose or just the type of person that was present who found the decedent. 93% of these are either family members, intimate partners, friends, or roommates. So a high number are people that the decedent had known. I would like to point out that, so the data that I had just given you, the high number of opioids, the location where the decedent is found primarily at home, the types of people who find the decedents. So these are all reasons why Maryland is very heavily focused on promoting naloxone use and access to naloxone. So we have these opioid response programs where patients can go and even family members, they can receive free naloxone if they have a person at home that they would like to have some just in case, or we do encourage everyone to carry naloxone, especially all of us that are working here in Baltimore. I mean, you never know if you witness somebody or happen to experience somebody who's going through an overdose on the streets. And so we do encourage naloxone access. Hold on one sec. Okay, so I would also like to, regarding the access to naloxone, I would also like to point out that Maryland does have a standing order, so pharmacies can dispense naloxone without a prescription. Right now, the recent standing order is issued by Dr. Rachel Talley with the Behavioral Health Administration. And so pharmacies are instructed to use, basically use her as the provider when they're submitting the information in their system in order to dispense that naloxone. And of course, the state openly encourages providers to co-prescribe naloxone when an opioid is prescribed, especially higher doses. So now I'd like to go into what the prescriber's role is in all of this. I know that the data that I had shared, many of the decedents had passed away likely due to illicit fentanyl. And we know that providers don't prescribe illicit fentanyl. But one thing that we would like to address is that when treating a patient with an opioid, we would like providers to be mindful if there are signs that patients may be becoming dependent on the medication, because it is an occurrence where the patient can become dependent and then things sort of get out of hand, and then all of a sudden they seek illicit fentanyl. So that's sort of what we're going to be talking about in a little bit. Ultimately, we would like to make a positive impact. Some of the safe prescribing practices would be to stay up to date on clinical guidelines, assess the risk of opioid use disorder with open-ended, non-judgmental questions, and watch for indicators of diversion or harm. Some of the questions that can be, some of the open-ended questions that you can talk to your patients about, they can include things like, how do you find yourself managing on days when the prescribed dose doesn't seem like it's enough? What kinds of worries, if any, do you have about running out of your medication before the next refill? They're not yes or no questions. They're just questions that, you're not accusing them of anything, but hopefully they'll be able to start a conversation that may give you some sort of indication whether they're becoming dependent on the medication. Collaboration is also another important part here, working closely with other providers, pharmacists, and working closely with the patients in order to manage pain effectively. Education is very important. Provide information on safe drug disposal and take-back events. The police departments and local health departments are great examples of, if the patient has extra medication that they did not use at the end of the treatment, they can go to those locations in order to have them properly disposed of. And also educate at-risk individuals on naloxone and overdose response. I would like to point out, educating family members is also important too. And it's not just about whether the patient is going to be the person that would need the naloxone. There are always those unfortunate circumstances where a child can get into the parent's medicine cabinet, and just having the naloxone on hand in situations like that and letting everyone know what the signs of an overdose are. That could really come in handy in emergency situations like that. I had mentioned keeping up to date on clinical guidelines. One of the major clinical guidelines for opioids is the CDC Clinical Practice Guideline for prescribing opioids for pain. This was released November 22nd, 2022, and it mainly talks about introducing guiding principles for implementation. It does go into detail about acute, subacute, and chronic pain, the definitions between the three, and recommendations around those. There is a shift away from the dosage thresholds and more on integrated patient-centered care. We do realize that not every patient is the same. Addressing health inequity and disparities related to treatment of pain, and broadening the scope of recommendations to outpatient settings and multiple types of clinicians. I'm not going to go through all of the recommendations and what they are, but they can be grouped into four main categories. You have recommendations 1 and 2, which are about determining whether or not to initiate opioids for pain. 3, 4, and 5 are selecting opioids and determining opioid dosages. 6 and 7 is about deciding duration of initial opioid prescriptions and conducting follow-ups. And then the last 5 are really about assessing risk and addressing potential harms of opioid use. Some of the more common recommendations, these are just the broad recommendations. They don't go into too much detail, but it's really not about setting rigid dose thresholds. That was some of the changes from the previous recommendations, and so they try not to set a certain limit to not go above, because the CDC acknowledges that every patient is different. There's recommendations on supporting slow tapers, maximizing non-opioid therapies, addressing health inequities, and assuring access to appropriate pain management for all patients. There are recommendations on offering to arrange treatment with medications for opioid use disorder, and also there's recommendations around reviewing the PDMP. And lastly, consider involving pharmacists in the management team when opioids are co-prescribed with other CNS depressants. Now I'd like to talk about indications of diversion and misuse. These are also red flags, essentially. Many of you probably already know what red flags are. So if there are patients or prescriptions originating outside the local geographic area. Now, keep in mind with the rural communities, access to healthcare can be a little bit sparse. So telehealth prescribing can be popular in the rural communities. And so if a patient has a provider that happens to be a great distance away, that doesn't necessarily mean it's a red flag, but just something to be mindful of. If there are prescribers practicing outside of their usual scope of practice, if prescriptions are written for higher than normal dosages and for higher than normal quantities, if patients are coming in appearing intoxicated, if patients are requesting early fills or refills, if there are patients with multiple prescriptions and or pharmacies that they go to, if you're reviewing a patient's profile in the CRIS portal, you can not only see which pharmacies the patient is going to, but you can also see what types of insurance the patient is using. Just keep in mind that if there's a patient getting the same medication from different pharmacies and they happen to use insurance for one pharmacy and then no insurance for another pharmacy, please keep in mind of that. Also, there's an indicator if multiple prescription medications are prescribed concurrently that may be misused in combination. I would like to mention that, so these indicators can mean that there is possible signs of opioid use disorder or diversion, but follow-up information is necessary from the patient in order to determine if the opioids can be prescribed safely. I should mention this does not mean that the patient is diverting or misusing the prescriptions, and it does not mean that clinical judgment should not be used to determine if an opioid medication is appropriate. And it also does not mean that individual patient factors should not be taken into consideration either. Some safety factors to consider when evaluating prescriptions and looking at a patient's chart. Whether or not there are other medications that may interact with the opioid, whether it's CNS depressants. Is the patient using alcohol or illicit substances concurrently? Is the patient aware of the risks associated with the opioid medications? And does the patient and or family members have naloxone at home in case of an opioid overdose? A lot of these are pretty self-explanatory. I'm sure most of you know these already. One thing I would like to point out, so when evaluating if you do see red flags, or when you're trying to look for red flags, there may be a patient factor that will prevent you from accurately looking in the PDMP profile. So the first item that we have on here, it says, has the patient's identity been verified? And I know that, it seems kind of obvious, but if a patient comes in and say if they had a recent name change, the name that they are giving you may not necessarily be the name that's in the PDMP profile. Whether it's just a typical name change or whether they got married, a different last name. There's different factors associated with that. But I would like to mention that it is possible that the patient's insurance may dictate what name is in the system. So for instance, the PDMP data, when you're reviewing the PDMP profile, since the data comes from pharmacies will dispense it with the same name that the insurance company has. So the patient may say that they have a different name, but whatever the insurance company has, that's most likely how you're going to find it in the PDMP. So if you can't find the patient's profile, just try to have a conversation if maybe they had a name change. Some clinical factors associated with this are if the opioids are indicated for the patient's condition, is the duration of treatment appropriate for the condition? Is the current regimen meeting the treatment goals? And do the benefits of opioid therapy outweigh the risks? So this is my last slide. If you do happen to find some red flags or indicators, it is important just to try to open up communication with the patient. Be empathetic. Try not to sound judgmental, like you're accusing the patient of doing anything wrong, because they may not be. Ask open-ended questions and use active listening techniques. Use clear terminology and avoid stigmatizing language. Approach the conversation as a discussion about risky medications, not risky patients. And of course, educate. If a prescription for an opioid medication is written, offer naloxone and educate on the appropriate use and disposal of prescription medication. Now I'd like to pass it on to Kyle, who's going to talk about the academic detailing program.
Hi, everyone. So what is academic detailing? So to start explaining what academic detailing is, I want to make a connection between what Brian was just saying in this section of the presentation. So essentially, all of those questions about evaluating indicators of opioid use disorder and evaluating whether something like an opioid prescription is still clinically relevant to a patient's given condition, these are all of the questions and topics, well, some of the questions and topics that we want clinicians to think about when we as academic detailers go into our detailing visits. So we know that you all face a demanding schedule, you the clinician. We know that you all face an information and evidence overload when it comes to sifting through information and trying to find the best available information in order to deliver the highest quality care to your patients. So we as detailers want to serve as honest brokers. We want to sift through that information for you and then come to our detailing visits and deliver the information in a way that enables you to improve outcomes for your patients, optimize your clinical decision making, and that sort of thing when it comes to delivering the highest quality care for your patients. So we want to deliver these recommendations in an actionable and tailored format, and I'll get more into how we do that, how we figure out exactly what's needed for your patient population as you go about your practice. And we want to engage in continued follow-up over time. So this is just a moment for me to say that we work in contrast to something like pharmaceutical detailing, which you may be more familiar with. We are not pharmaceutical sales reps. We don't go into visits trying to sell you anything. What we do is our bottom line is the information that we're trying to give you in order to help you optimize clinical decision making. So a pharmaceutical sales rep is trying to sell you something. They're trying to sell you the drugs that their company manufactures. They're trying to get you to write more prescriptions for the drugs that the company that they work for manufactures. But we, as an academic detailing, not pharmaceutical detailing, we go about our bottom line as trying to help you improve patient outcomes. And that's really the measure of success, the metric of success for what we want to do as academic detailers. So to get more granular in terms of what academic detailing is interactive one-on-one in-person conversations with clinicians. We tailor the information that we deliver to you during an academic detailing visit to your practice, specialty, and workflow. We want to deliver evidence-based and clinically relevant recommendations. And again, in contrast to pharmaceutical detailers, we're non-commercial and we deliver unbiased information straight from the same sources that you can find the information. Also, in terms of the behavior change focus, you can see there are some key differences between traditional clinical education and academic detailing methodology. So traditional clinical education might include passive education, a single intervention, or generic written materials. But in contrast, academic detailing, we want to hear your feedback in real time as we deliver the information to you. That's going to make the visit more memorable. So we go into our visits thinking that we want an interactive one-on-one in-person session to facilitate two-way dialogue. Again, we want to hear your counter arguments. We want to hear all of the information that you have in response to the information that we're delivering so that we make the visit more memorable and more beneficial for you. We also go into each detailing visit knowing that we want multiple interventions to yield stronger and more sustainable outcomes. So similar to pharmaceutical detailing, but not exactly the same, we go into each visit trying to build trust and rapport when it comes to making a connection with you and maintaining that connection over time and reinforcing the recommendations that we're giving to you with each visit. We also want to deliver tailored messaging to fit each provider's needs, specialty, and workflow. So when I was detailing in Washington County for the Washington County Health Department, which I did for 3 years, I would go into a visit with a primary care physician or even a physician in something like pain management with a much different mindset than I would go into a visit with a pharmacist. So when I detailed to a pain management specialist, I know that I'm going to see somebody who's probably already prescribing opioids, probably has patients who are on pain management medications that have been on them for a long amount of time, and I don't want to go in necessarily trying to overhaul everything that they're going to do. As opposed to when I detail to a pharmacist, I went in with my pharmacy guidebook, and I'm talking about using non-stigmatizing language, which you can use with physicians too. But I'm trying to make an impact on what the pharmacist can do with their patients in terms of using non-stigmatizing language and dispensing naloxone and all the things that a pharmacist can do in the window of time that they have with each patient that they encounter. So here's the structure of an academic detailing visit. Earlier, I said I was going to tell you how we go about finding out what each clinician needs that we come into an encounter with as an academic detailer, specifically for Detail MD. This is also a good moment for me to say that we specifically focus on opioid safety, opioid stewardship, that sort of thing. So when we go into visits, we have a predetermined set of key messages, a range of key messages that enables us to pick which key message is relevant to each visit that we go into when we visit with you, the clinician. So I'm going to briefly take you through the structure of a visit to help you get a bigger idea of what's going on when we go into an academic detailing visit. So the first thing I would do is introduce myself and give you a little bit of background about academic detailing when I visit with you. And I would do that in a way that gives you a slightly better idea of what academic detailing is. It's educational outreach. I'm there to talk about opioid safety. I'm there to give you some recommendations on how we can improve your clinical practice. So I would give you an introduction, give you my name. I'm with the University of Maryland, that sort of thing. And then I would go into our needs assessment. So this is the portion of the visit where I do find out what's needed for your practice. So I'm going to start asking questions. And even when I detailed, when I was in Hagerstown doing academic detailing, I would meet with a clinician, and one of them said, "Is this an interview or are you delivering the information?" and that sort of thing. So what I said was it's a little bit of both. So we start asking questions and then we deliver information in a way that shows you that I'm a credible and trustworthy source of information. So starting with the questions, that gives me an idea of what would be more beneficial to you. Because if I'm giving you information that's not beneficial, then I'm not necessarily doing my job. So I would start asking questions. If I'm talking about the PDMP, for instance, then I want to go and ask you, what has your experience been like using the PDMP? How often do you use the PDMP? What are you trying to get an idea of when you use the PDMP, when you're looking at your patients' profiles? But specifically, I want to talk to you all about avoiding concurrent prescribing. So that's an example of what I would do if I was talking about our PDMP key message. But with avoiding concurrent prescribing, I would specifically start asking you questions like, how do you identify patients who are prescribed opioids and other sedating medications? And you might come back and say something like, well, we check the PDMP every so often to get an idea of a patient's medication profile. And I might say, well, how often do you discuss the overdose risk that comes with being prescribed opioids and other sedating medications? Now, as Brian said, that doesn't necessarily mean that every patient who's on opioids and other sedating medications is immediately going to divert them or misuse them, or that they're in some imminent danger. This is simply a way for me to gain an idea of what you do in your practice when it comes to this specific overdose risk. And I've learned that patients who are prescribed opioids and other sedating medications are at a 4 times higher risk of overdose when it comes to that medication combination. Again, that doesn't mean that they're in some imminent danger, but it does mean there's a risk there. So I might say, well, there's a missed opportunity here to discuss this specific key message. And I would tell you the specific key message as I go into this key messages part of the visit. I would tell you that you want to ensure patient safety by avoiding concurrent prescribing of opioids and other sedating medications, and discuss storage and disposal guidance. That's our specific key message that our organization Detail MD has already predetermined. So when I go into this key message part of the visit, I'm going to tell you why that might be a missed opportunity. I'm going to tell you about the overdose risk. I'm going to tell you about all the features and benefits that come with standardizing the process of talking to each and every patient who's prescribed an opioid and another sedating medication, what that could look like, and how that could improve outcomes for your patients on an education and awareness scale. And then, of course, you might come back and say, well, I have patients who have legitimate indications that they should be on opioids and another sedating medication, such as a benzodiazepine. You might say something like, well, I have patients who experience chronic pain and severe anxiety, so they need both of those medications. And we don't want to put them in imminent danger by this. We don't want to make them seem like they're in imminent danger by discussing the word overdose or anything like that when it comes to standardizing the discussions that you have with patients. But we specifically want to, again, I'm going to tell you that there's a missed opportunity there because patients are at an increased risk of overdose when they're using opioids and other sedating medications. I'm going to tell you about all the ways you can look for a safer alternative, if that's possible, in terms of NSAIDs for chronic pain, for acute pain, and that will be non-steroidal anti-inflammatory drugs. So I'm going to tell you about all the safer alternatives you can review when it comes to switching out for a non-opioid medication, if that's possible. I'm going to tell you about a dose reduction, if that's possible, in terms of reducing the risk of the opioid itself when it comes to that medication combination. And I'm going to tell you all about co-prescribing naloxone too, as you talk about what's needed for a patient who is prescribed those opioids and benzodiazepines or opioids and any other sedating medication. So then at the end of the visit, I'm going to tell you a summary of all the information that we talked about. I'm going to give you some information. I'm going to tell you everything, sum up what we talked about, and I'm going to look to schedule another visit with you. So over time, as you can see, that third bullet point, over time, second bullet point, the visit ends with a specific practice change recommendation. So I'm going to tell you something at the end of the visit that I would like for you to do and bring to me in the next visit as we reconvene. So I would ask you to do something like, can you identify 5 patients in your practice who are prescribed opioids and benzodiazepines? And next, when we meet in about a month in our next visit, let's discuss those patients and let's discuss the barriers to avoiding concurrent prescribing of opioids and other sedating medications that we could look into when it comes to avoiding that combination with the patient. And I would also, well, it depends on whatever is needed for your practice. So if I want you to do something different, it might be something like, can you identify one situation where we can avoid benzodiazepines specifically? Or it could be any number of things when it comes to the practice change recommendation. But I'll ask you to do that, and I'll ask to meet with you again in, say, a month or something like that, and we can reconvene. And over time, the relationship between us will be strengthened. You'll see me as a trustworthy and credible source of information as I keep bringing the information back to you in future visits, and we'll review your successes and challenges that you've had over the month that you've had time to do the tasks that I assigned you. Okay, and this is my last slide, why academic detailing works. So academic detailing, we do all of this because this is an evidence-based intervention. It's all been shown to do things like increase the likelihood of checking the PDMP prior to opioid prescribing. Academic detailing has been shown to reduce the variability in opioid prescribing, improve knowledge of naloxone administration, or in my specific case, as I had with a prescriber, increase the likelihood of co-prescribing naloxone. So again, when I was detailing for the Washington County Health Department in Hagerstown, I specifically came into contact with the pain management physician who was already prescribing opioids for his patients. And when I detailed to him, I specifically talked about the key message to co-prescribe naloxone. So in this instance, I came away from the visit having told this provider about all of the benefits of co-prescribing naloxone with every opioid prescription. And I think that got the wheels turning, because afterwards, this provider called me and tried to ask for specific ways we could either get naloxone in his office, or specific ways that we could set up an arrangement that would make it easier for his patients to get naloxone from something like our health department or another organization. So I think that got the wheels turning, and I consider that as a success for my academic detailing journey, and that I got this provider to start thinking about something like co-prescribing naloxone. And as you can see from the box to my right, right? I don't know. You can see that there are successes for other academic detailing interventions as well. And so generally, these are all the benefits that can come if we implement academic detailing successfully. And now I'm going to turn it over to my next presenter, Nicole.
Thanks, Kyle. So now I'm going to talk about the specific program of Detail MD, which is the Maryland Academic Detailing Program. So this program was it piloted in 2019, funded by the CDC and SAMHSA grants. And our overall program goals are to improve opioid prescribing practices, prevent opioid-related overdose deaths, increase clinician use of the PDMP, as well as augment the skill set of Maryland's public health workforce, because currently the detailers are all local health department employees. So it's sort of building that relationship between local health departments and clinicians in the community. We're hoping to grow it and expand who detailers are, though. So this slide is sort of an overview, kind of describes the program in more simpler terms, right? Kind of taking away what is going out to the community being like academic detailing. What does that mean? Overall, academic detailing is educational outreach. It's educational outreach for medical providers to sort of help support the tireless dedication you have to Maryland patients and the overall community. The focus of our program is to increase clinician use of evidence-based recommendations for opioid prescribing, opioid safety, and implementation of best practices. And through the detailer's role, they help clinicians better understand current research, prescribing guidelines, and best practices. So we like to share that the overall benefits is helping with the daily challenges of providing patient care can be demanded enough. So as a detailer, they are there to help better understand what the current research is, the prescribing guidelines, and best practices. Sort of what Kyle mentioned, just kind of like diffusing all that information overload to try and be specific within your practice. And so the outreach educators or academic detailers can share the best practices, resources, and tools to help streamline your workflow and improve the outcomes for your patients. And currently, most of the sessions happen in person, but also can be done virtually. And so all of these, the education of the best practices, resources, and tools are utilized through guidebooks. So for prescribers, we have specific guidebooks with the best practice and evidence that's been developed and adapted through a standardized guidebook that has Maryland specific information as well. And then we have a pharmacy guidebook. So the core messaging for both prescribers and pharmacists sort of are based on the CDC guidelines that Brian went over. So these lists the 6 key messages that are discussed with prescribers. And sort of how Kyle touched on it, we don't go in with the goal of we're going to talk to you today about these 6 key messages. It's really based on that needs assessment question, really determining which way our conversation is going to go. And based on that, you sort of then just lead towards one of these 6 core messages. And like we like to tell some of the detailers, there also are sort of these like sub messages that kind of go along the key message. So for instance, for key message number 5, offer treatment for patients with opioid use disorder, one of the sub key messages that sort of goes along with that is screening for just screening in general, screening for substance use, as well as the need for any use disorders. And so it's not, the main message isn't necessarily screening, but if screening isn't occurring, we can't really offer treatment. So that's been a really that's been a pretty common key message or sort of sub key message that's been coming up when having discussions with providers in the community, is really assessing how well are they assessing their patients and having those conversations to then determine some of these other conversations to have. So the key messages for the pharmacists sort of correlate with the prescribers, except for specifically prescribing. And so same key messages of using the PDP. So talking about avoiding concurrent dispensing, and then offering treatment, and then dispensing naloxone, as well as having conversations around naloxone. This slide kind of goes over some of those behavior change commitments that sort of close the academic detailing session. So some of examples of behavior changes that providers have committed to are using the PDMP, prescribing naloxone. That's one of the top behavior change commitments that we have seen. Screening patients, prescribing buprenorphine, and then these next ones are a little on the easier on that like low-hanging behavior changes, but still important to start that movement of being able to discuss safe storage and disposal and provide those specific resources. Providing resources on naloxone is just really starting to have that, not just prescribing naloxone, but also having that conversation about how to use naloxone and when they should use it. Providing resources on treatment. One thing that has been a success is sort of this build in the knowledge base within the jurisdictions of all the resources that exist in the community. So by having like the partnerships with the local health departments, a lot of local clinicians are learning all the resources that exist in the health departments and being able to just use that as an additional resource of just having this list of resources that exist in the community that they maybe weren't aware of, and then avoiding concurrent prescribing of opioids and other sedating medications. Pharmacists, similar of dispensing naloxone, screening patients, and then the same ones. So the detailer's role, they provide the Detail MD, they promote Detail MD using, we have universal materials for all of our communications. They conduct the field visits or the detailing sessions with the clinicians and schedule the follow-up visits with trying to schedule within 48 hours, include their behavior and practice change, and there is an evaluation survey component to try and see how well the visits went and what clinicians' takeaway was. So some of the resources, like I said before, are the pharmacy guidebook. We have a tailored CHOW guidebook. So that is CHOW is out of San Francisco. It's their California something opioids. And then we have our fact sheet and flyer, which we actually have a few with us today that we can share with you guys, and as well as additional resources, which I'll show you some examples of what those look like. As a clinician, we ask that they, can complete this brief online evaluation just to see how well the visit went, as well as what any commitments or behavior changes that they are planning to implement, as well as any barriers, so that we can kind of see more at the state level, what are some common barriers? And is it more workflow? Is it stuff that we also work a lot with MACs? Is it stuff that can do more universal additional programming? Does it need policy? All of that stuff. The expectation, like Kyle talked about, is to engage in multiple sessions over time. It's not a one-off type of program. It's to be able to build that relationship and solely go through and how can we help improve in patient outcomes. And also, by completing those online evaluations, you can earn CMEs after each visit. So we just wanted to come today to also talk about how Detail MD could work with the University of Maryland and build that partnership. So one of the things is, like, one of our main goals is really talking with primary care, internal medicine providers as like that hub with the patient, as like to really build that partnership of just screening and as well as just best practices. How really to, I don't know, as a follow-up of how we can integrate and expand academic detailing within the University of Maryland system here, as well as across the state, since there's clinicians all across the state that are under the University of Maryland, the University of Maryland system. And so as we can be the bridge to then connect those prescribers with the detailers in, within the state. So we can like kind of expand and really improve practices across the state. And then also we have started promoting and pushing out information on LinkedIn. So you can feel free to scan the QR code and follow Detail MD. Let you guys do that if you want. And I'm not done. And this is just real quick to show you some examples of resources that we provide during the visit. So we've provided individual data snapshots for each at the jurisdiction level, just to kind of utilize and see like sort of what it looks like at the county level. Some tip sheets. So the one in the middle is an example of how I've been talking about naloxone, some conversation starters and some language and how to have that conversation to bring it up with a patient. And then the last one was an example of how we look at current research articles and sort of take some key messages away from that and tie it into why academic detailing fits into the current landscape. So this was a research article saying that many Americans are unaware that their primary care physicians can prescribe medications for opioid use disorder, but that they also feel like they would be a trusted person to like have that conversation. So just showing that why primary care can be a good resource for trying to support medication for substance use and all of that. So this is just an example of our outreach information and how to schedule. This QR code can take you to schedule a visit directly. And yeah, that's it. Any questions about anything that's been shared today?
Just want to thank everyone, the ICTR and the Department of Medicine. Thank you.
That was great. And I think clearly more effective than blowing Venezuelan fishing boats out of the water. I have one question. How does this program compare to what other states are doing? Are there similar programs in neighboring states? Is this unique to Maryland?
So academic detailing is an evidence-based program that is being done actually internationally, like on different topics, but in terms of like, so all different sort of like patient outcome approaches. We work a lot with NARCAD, which is now I'm going to be bad with all the acronyms, right? So they're essentially the National Academic Detailing Resource Center, essentially. But so there are examples, I don't know, and they kind of implement them differently, like some are and how they're either voluntary or like sort of like recommended. There's different approaches. So some are tied more to like maybe like insurance, or hospitals can like thresholds to be like, oh, we want this provider to now have this sort of like intervention to improve maybe their prescribing, but saying in a nice way. So there's nothing in Maryland that it's all voluntary. We're trying to increase the participation, but there's nothing of where because you are red flag in the PDMP, you have to participate. At this point, there's nothing that because of the laws but there is evidence and there's lots of different approaches. I know that there's a program, University of Illinois Chicago at our school pharmacy. They have a pretty strong academic detailing program, and opioid topics is one, but I think they have like 10 different sort of topics that they talk, like diabetes management, other types of things. So yeah. Any other questions?
Very nice.
Yeah.
Quick question. So we have sort of a large footprint thinking about our medical system. We have a limited resource, you guys. So two questions. Are you targeting certain areas and certain specialties that you want to talk to? I see primary care docs is a big one. So who are they and how, can we help facilitate that? And then the other thing is sort of force multipliers, sort of AI, alerts in the medical record, sort of agentic things to sort of remind clinicians of what to do and how to prescribe. How much are you guys also working in that front?
first question is that's one of our goals of like trying to do more of these conversations to build these relationships and partnerships. So like I said, we've piloted it and worked a lot with the local health departments. And for the first like 4 years, it was a lot of like almost bottom up try of recruitment. So a lot of these detailers in the counties were just like essentially cold calling, like showing up at clinician offices and being like, hey, will you participate in this program? And to get through even like the front desk, you know, to talk to an actual like physician was difficult. So we came up with a different like outreach approach, and one of our goals was trying to talk to more medical systems and seeing if we can have kind of build those relationships to see more buy-in, and then how can we then from there work with like higher level people to get able to reach clinicians across the state. In terms of the AI stuff, we haven't really, I think that's some of the workflow that we could learn of like what could help. And that sort of ties back into like why the evaluation is so important. So then we can see like, are there tools that could be better helpful for clinicians to implement some of these best practices, or do they already have some of that stuff in their workflow? I know some pharmacies, I think, have that, or other systems, but I don't know, like each obviously different computer systems do different things. So, I mean, we don't know what people are doing. And maybe through this, we learn that there are some really good programs or, you know, alerts that people have worked that we could share, you know, through this with others. Be like, oh, here's how you could do this. And we could compare and see how it works. But yeah. Do you want to know anything, Brian? Okay.
What do you think has been your biggest impact so far?
I think slowly building some of the relationships, I would say, like through some of the jurisdictions that have had continuous sessions. Like, so we have a few detailers that have really made an impact of just like building that relationship, and started off more of those like easier tasks, but have had some follow-up conversations. So of course we've got one of our biggest things people are willing to do is, you know, co-prescribe naloxone or dispense naloxone, but then trying to have more of the conversations of screening or the concurrent medication. So I think one of our detailers like came up to a situation through learned like sort of a specific patient scenario that then we brought back to have discussion of how they could handle that more unique patient case. And then is that something that would be, is a more universal situation? And how could we then share that with all the detailers? So we've had some conversations with like the Max consultants. And then we also do utilize, I wanted to mention that's one of the tips too, is like within the one-on-one, if it's like a more complex, like clinical situation, we lots of times the detailers might utilize the Max warm line, and so they're introducing that as a resource that they might not even be aware about, and then also can follow up to be like, did you set up maybe like a one-on-one TA with like a Max consultant to kind of work through that, but as a detailer we can follow up and see how that goes. So I think it's also bring in all these resources that exist. Obviously, there's all the guidelines, but all the resources that exist in Maryland and in their local communities that maybe aren't aware of. I don't know if Adrian or has said anything else.
I mean, pretty much.
Okay.
So to follow up, congratulations to everyone. Great presentation. A couple of questions. So how often do you get in to see the prescriber a second time?
Mm-hmm.
And how often do they ask you about other conditions? And you talked about the really prevalent common chronic disorders. So diabetes, hypertension, for example.
I have to pull up exactly so I think we are improving because we basically have really emphasized over the last like year and a half, 2 years, the goal is actually to not reach as many people as you can, but it's actually to increase the visits with like So if they are we don't want them to have like 21st visits. We'd rather people have to reach four physicians and meet with them if even it's every quarter, that you're just like building off of that. And I think we have seen that improvement by that emphasis. I'd have to pull the numbers, but there is a good amount. I would say like half, would you say in the last quarter, about half were a follow-up. Most of them were follow-ups. So that, and not just a second, but like third or fourth visits. Yeah. Mhm. Mhm.
That's a critical point.
Mhm.
I would say personally, I got into a second visit with most of the people that I started visiting with after about a year or so of doing it, when I realized that that could be more beneficial. But as Nicole was saying, like most of our visits, and this is data that I review now in my current role, like every quarter, every so often. So most of our visits have been repeat visits. They've been, and across the state too. This is Anne Arundel County, Cecil County. This is across the state that people are getting in the third or fourth time. And as she said, it strengthens the relationship that you have. So even a provider might spread the word to another provider, and you have a exponential sort of reach that you can have just by visiting with the physician more than once.
Yeah. In terms of other conditions, not quite sure. We are expanding like the detailers fill out the session report form, and we have more notes and other things that come up that we're gonna introduce that new form. So we'll collect a little bit more, but we can definitely follow up and ask how much like other stuff comes up.
Dealing with chronic pain is a challenge. Meaning, which specialty deal with chronic pain? I would say all specialties, including rheumatology, meaning chronic abdominal pain, chronic chest pain. Every specialty will deal with it. How do you signal who's provider you need to reach out? I mean, are you looking at the prescription pattern, or like?
Yeah, I would say ideally we started with the focus with primary care, just of like trying to just do the bringing stuff into like a one like home, like medical home type thing, especially with like screening and not always trying to reduce so much of the referral out of everything. And so trying to screen and prescribe like like medications for opioid use disorder or others, so that it's not just like we get there. I don't do with that. We refer to pain management. We refer to treatment instead, by having these conversations of like, there's so many other conditions that interact or can relate. So it's better to not treat it as like this refer out situation. But I mean, I think like as we build, there's nothing saying that we don't want to talk to all specialties. It was more of just a starting point, and there's definitely been detailed visits with other specialties that people have had because they were able to get in. Like I said before, it was like, who can we get a visit with? But yeah, the conversation is important with all specialties. I mean, it's important of just like having that open, honest conversation with the patient, screening, having those discussions. There's risk with any medication. And so just being able to have that interaction is helpful across all.
Yeah, exactly. I wanted to just add up and perhaps wrap up. But again, expanding to all chronic care potential sources, as well as hypertension, diabetes, other chronic conditions, would be the next frontier. And perhaps utilizing some of the tools that now are emerging, agentic AI or others. Perhaps we have the data and the PDMP, and maybe building that community. As Nicole and Brian and Kyle were saying, really, we are building community here, applying now academic detailing, but again, with the purpose of expanding it across the spectrum. So this will be the next step, and we do need collaboration. So certainly this is a call under the ICTR. We are DNI, we have different identities. So we are DNI, dissemination and implementation under the ICTR. And this is where our line of communication, I think, with clinical care and clinical research is. And perhaps this might be the venue for building on our academic detailing program. So I'll yield back to the chief.
Yeah, I think the QR code, that takes to the site, right? Or to sign up. Yeah, that QR code takes you to the landing page for the MDH or to sign up. So, and follow us on LinkedIn too.
Thank you so much.
Thanks.